Good morning, everyone. This is Gail Strack. I'm the CEO of Alliance for Hope International, and I get to oversee the Training Institute on Strangulation Prevention and also host this amazing webinar today. So what we're going to do is something a little different because we want to know who's on the call. So we're going to be brave and start off with a poll question to get a sense of who's on the call so we can direct some of our comments towards you. And I'm happy to report that this morning when we checked to see how many people were registered, we found out that there are 1,334 of you. Like, holy moly. My little grandson would say, holy macro, Gramacita. So we'll go ahead and take a minute or two to go ahead and do that poll. And it looks like you're already signing in. We are at 75% voted. We're going to try to go all the way to 100%. And as the numbers are coming in, it's no surprise. Looks like the dominating discipline. We're talking to a lot of advocates and counselors today. Fantastic. Looks like the next big group are the medical providers, doctors, nurses, and paramedics. We've got a great percentage, about 12% right now, of law enforcement, and then our FJC directors and other policymakers. And we are now at 86% voted, just to let you know where we are. And we will be wrapping up this poll shortly. And it looks like we're at 59% advocates and counselors. Fantastic. I might explain why I feel so much love in this webinar already. Poll is closed. Thank you so much for everyone joining us. So welcome to our webinar for the Alliance. This is the largest webinar we've ever had, and I think there's a reason for it. This is obviously a need. I just want to share a little background on how this webinar came about because it really is a team effort. Today we are partnering with our OVC friends and OVW friends. But this really grew out of a great discussion from the OVC Initiative and Family Justice Center directors. And at the same time, as we've been doing trainings across the United States, it has been percolating all around. So after you receive the strangulation training, what do you do and what should we do? What should be the emerging and best practices that as we identify that victim, that patient, that client who has recently been choked and thought she was going to die, what do we need to do as they're coming to our offices to get restraining orders, coming into hospitals for treatment, going to a family justice center for a restraining order? How do we handle that? So that's what we're going to tackle, and we're going to be hearing from some amazing speakers that are going to give us the newest and the most hot off the presses information, and also very inspiring talks by a number of people who've already integrated their strangulation training into practice and into their organization. So that's a picture of me. I am now a grandmother of 2. I was so tempted to put in my grandchildren's photos, just like Jackie Campbell does, because as you know, I've told everybody all around the world, I've got a girl crush on Jackie Campbell because she's just so amazing. And one of the things that she always does is she honors her children and grandchildren. But I do want to start with a very heartfelt thank you to the Office on the Violence Against Women. We most recently had a master's course with 65 amazing professionals from across the country. And it was a heartfelt thank you, and I hope OVW and OVC feels that from the Alliance. So Katie Sullivan and Kevin Sweeney, thank you so much for making this webinar possible and supporting our work. We also want to thank Stacy Phillips and Susan Williams and Darlene Hutchinson. I almost lost that thought for a moment there because I was just getting so emotional, just going, yes, we get to do this with 2 amazing organizations. I also like to share, as everybody knows, our team. Yes, you are right. Our team is definitely getting bigger, but we've got a couple of folks that are here with me. I feel like we are putting on a radio show here. To my right, we've got Sarah Dillon, who is working with us and helping me with the Training Institute. We also have Gloria Chalo, who is representing OVC and really taking the lead technology role on all of this webinar today. And we have someone that we have hired recently, Patricia Middleton, who has joined us and is also working on our FJC, OVC, and strangulation work. And hopefully you've had a chance or will have a chance to meet the other great folks that are working with us at the Alliance. I just also want to remind folks that what we're trying to accomplish today, but this is definitely trying to get to the heart of the impact of strangulation. As we all know, there are immediate consequences that we're very concerned about, but there are also delayed and long-term consequences. And I think from the very beginning of my work, that became very real as women were contacting us, trying to figure out what was wrong with them months and months later, and how can we help them. And then most recently, I was reminded again about how important this topic is when a mother came up to me and in tears after strangulation training, kind of pulled all the pieces together and realized that her daughter had suffered much more than she ever realized, because as she was crying and tears were running down her face, she just kept saying, "I want my daughter back. I want my daughter back." And then shared that her daughter had been strangled repeatedly, but didn't realize the the ultimate impact. Initially, we think it's depression. We think it might be PTSD, and that can be treated. But now we know it's so much worse. So to be able to have this conversation today really makes us really excited to be able to share it with you. We also wanted to share what people are doing at family justice centers and hospitals and multi-agency organizations, and also continue to think about this. As part of this preparation, we were able to have a work group of professionals. I think we had about 25, just helping us think this through. So this really has been a webinar that has been in the works for at least 6 months. I call it the homegrown webinar, and it's coming from the field. So hopefully we can achieve our objectives. We definitely want to learn more about the danger assessment tools, because there's so many things that are new and new research articles. Our team at the Alliance will be updating our bibliography, so this way you can have access to all of those articles as well. And then, as I mentioned before, continue doing our thinking. So it's my honor right now to introduce somebody who really needs no introduction, and that is Dr. Jackie Campbell. Many of you know her and you know about her work. She is definitely one of those national leaders. I call her behind her back a rock star, and she's been doing a lot of research and doing advocacy, thinking and writing and advocating. And she's also been part of our medical advisor. So I am really honored to introduce Dr. Jackie Campbell to you, and I'll be switching it over so Jackie can take control.
I developed the danger assessment way back in 1985 is when it first started. The first version is copyrighted in 1986. And here on this slide, you see the danger assessment website, and you can go there and get the most up-to-date version of the danger assessment that I'm going to show you, as well as other articles that go along with it, other information about the danger assessment. When I originally developed the danger assessment, I was working from a small study of domestic violence homicides. That study was published in 1981, and everything else I could read about domestic violence homicide, because from that study it was clear to me if I wanted to prevent homicide of women, I needed to work with domestic violence victims, because when women are killed, and this is still true in this country, they are killed most often by a husband, boyfriend, or ex-husband or boyfriend, and they have, in at least 70% of the cases, been physically abused before they were killed. So I started working with women in support groups at domestic violence shelters. I was also working with women who came to me as a nurse in healthcare settings. I was also teaching student nurses to identify abused women. So I was talking to a lot of abused women as I was in this process of working with domestic violence. And one of the things I found was that abused women oftentimes underestimate their risk of being killed. This is normal behavior. It's not stupid. It's not denial. It's that you can't go forward and function well if you are constantly thinking about the risk of being killed by an abusive partner. So one of the things I wanted to do was help women have an accurate assessment of how much risk of homicide there was in their situation. I felt like women needed to know that, along with other information, in order to make good choices about their future. The other thing I was learning and working with women in support groups is how smart and strong and resourceful they were. So I started out with this list of risk factors from my research and other research. And I asked women in support group, what else scares you? What else makes you feel like he might kill you? And that's when they first told me about what they called choking. We now know as better termed strangulation. But back in 1986, I worked with a master's student, and we published a paper on the choking that women were experiencing in abusive relationships, which, as I said, they called it choking. Women told me that the most frequent way they were, quote unquote, choked is a forearm against the throat, against the wall, and then the abuser would only have to lean a bit in order to totally cut off her breathing and totally subdue her. And so women also talked about having hands around the neck, his hands around their necks. And also more and more they talk about chokeholds, which I worry every mixed martial arts class in America is now teaching. So when the danger assessment was first copyrighted in 1986, the choking item was on there. Then we further tested the danger assessment in our National Intimate Partner Femicide Study. Those results were published in 2003. The accuracy of the danger assessment itself was published in 2009. Both of those articles are available on our website. And you can see here an ROC curve analysis of the danger assessment, and that we were able to accurately capture 90% of the cases under that ROC curve, which just says that it is quite accurate in terms of helping women determine their risk of homicide. And you notice how I say that, helping women determine their risk of homicide. The danger assessment has always been for abused women. It's not for us, no matter what part we play in the system. It's primarily for her. We also get some additional information from it. It's a good way to assess with an abused woman what's been going on in the relationship. So the new, now I've lost my arrows. I was going to go to the next slide, but the arrows are gone from the bottom. There, thank you. Whoever's out there helping with all of this. So as I mentioned, the choking item was added in 1986, 1987. And then we specifically looked at the risk of femicide, homicide of a woman by a male partner. In 2008, Nancy Glass, my colleague, was the first author on that article. What we found from the National Femicide Study was that a choking, what women called a choking incident, increased her risk of actually being killed. This is the bottom one, by 7.5. And that's adjusting for demographics. So it increased the risk of her being killed by 750% if she had had, and the item reads, have you ever been choked by your abusive partner? It increases the risk of a near homicide by 6.7, and again, 670% if you wanted to do it percentage-wise. We also have looked at the prevalence of the strangulation, and when we look at the prevalence amongst women who are killed or almost killed, it's at least 50%, and I say at least because the information about choking strangulation amongst the women who are killed or almost killed is from a proxy, a family member, or a close family friend. They may not have known about all of the strangulation incidents. Other abused women in the same cities, which is our comparison group, there was only 10% of them, and these were women that were never killed or almost killed. We actually interviewed them, had experienced a choking event. In another study of abused women in the community, we found that 21% had experienced strangulation. So clearly, it's abused women who are severely abused, who are in more risk of homicide, who have experienced strangulation events, more so than abused women who are not that seriously abused. So that's why Casey and Gail are finding high prevalence of strangulation amongst women who come to family justice centers, for instance, because they are more seriously abused and are therefore reaching out for help. So it is a sign of a potentially fatal event. One of the other things that's happened with the danger assessment is the My Plan app. And it's available in all the app stores. It's all one word with small MY. There's about 6 or 7 last time I looked, My Plans in your app store, but there are different variations on that. Look for the little leaf. It is an app that was developed by my colleague Nancy Glass that also contains the danger assessment. It is not meant to take the place of domestic violence advocates, but rather to be an additional tool that you can use to help abused women, first of all, understand what's happening. It can also be done by a friend or family member. There's a pathway for that. It starts with secure access. We all know what a challenge that is in today's world in terms of the more surveillance, the more dangerous the abuser is, the more likely he's to go through your phone, he or she, to go through your phone, be surveillant about what you've got on your phone. We always advise women, rather than there is a PIN code, et cetera, there is some verbiage about keeping your app secure, your phone secure. But I always advise women go through it, and then when you're done, take it off your phone so it's not there, or go through it. You can also go through it on somebody else's phone or somebody else's tablet or an agency tablet. The cool thing about it is it builds in the danger assessment in it, and it does the automatic weighted scoring and puts the woman at one of these levels of danger. And you can see it's in the red zone, that's extreme. In the orangish red, that's severe. In the plain orange, that's increased. And then this is variable, the lower one. So it scores the danger assessment for her. That color coding is, we have done some analysis of it. People remember where they are, and it says here's where you are in terms of risk of a homicide in comparison to other abused women. Then it also asks her what her priorities are. And like if her children are priorities, then the plan, my plan that comes out at the end, has a lot of things about keeping children safe. It's also tailored to her level of danger on the danger assessment. So the wording about the plan is much stronger if she's at severe or extreme danger. So it's very much above my level of programming. I know nothing, but it's very strategically programmed. And Dr. Glass has worked hard on that. So I wanted you to know that that's a new thing that's out that has the danger assessment in it. Now, the other thing that just came out, and this is updated in 2018, hopefully, it's now the one available on the website, is the danger assessment with some adaptation. I've finally gotten Gail and Casey's messages to heart. So I finally got the language much more indicative of strangulation events versus the choking kind of notion, even though that's language, again, that abused women still sometimes use. So first of all, in the calendar, one of the things about the danger assessment, that calendar is extremely important in terms of her documenting what's been happening in the relationship, the pattern, whether or not the abuse is increasing in severity or frequency. She sees that for herself. One of the other things that we are, as we get more knowledgeable about issues of triggering, the latest science supports the notion that if someone has PTSD, that if we can keep that person in their frontal cortex, that they're much less likely to actually be triggered and experience anything like dissociation or being tremendously traumatized by thinking about what has happened. So the calendar is very useful for that purpose, as well as helping her see for herself whether or not the abuse is increasing in severity and frequency, or whether or not there's some pattern that she, and ideally an advocate, can identify that helps with safety planning. So what's new, number 4 on the calendar says permanent injury, miscarriage, or choking, and then use a little copyright sign in the date to indicate choking, strangulation, cut off your breathing. For example, 4C. So this is a really good way for an advocate to identify if there's been a recent strangulation, in which case there are protocols that need to be followed to get her to emergency care or back to emergency care if there wasn't a good evaluation in terms of the strangulation. It also identifies quickly if there's been more than one strangulation, which is incredibly important. So the other advance is the wording of number 10, which used to say, does he ever try to choke you? And that was it. So now it has the language, does he ever try to choke / strangle you or cut off your breathing? And then importantly, 10A is, if yes, has he done it more than once, or did it make you pass out or black out or make you dizzy? So some sign of an alteration in consciousness. Notice I say alteration in consciousness. We oftentimes ask, did you lose consciousness? There's a whole continuum of alterations in consciousness, all the way from, total coma on one side to totally unaffected on the other side. And it's important to know if there's been any alteration in consciousness along with this strangulation event. So we also know from more recent data that if he has done it more than once and or it resulted in an alteration in consciousness, and notice it's pass out, blackout, or make you dizzy. This is much more language that abused women can relate to. So that's, again, all of the language on the danger assessment, tense, et cetera, has been very carefully chosen. So we tried to make it clear that we're looking for any alteration in consciousness. And then if that's true, this more recent data shows that makes it even more likely that she will be killed. So this is the strangulation calendar directions here, and just in larger print in terms of the use a C and the date to indicate choking or strangulation. How did I go backwards? I didn't want to. Okay, we'll try again. This one? All right. And then the data that I was talking about, we did a study in Oklahoma, 1,008 women. This was part of the LAP evaluation, so there's several publications on this. So that the data from this is available in a Messing and Patch 2018 in Women's Health Issues. The findings specific to the choking strangulation events, we found, now these were women who had all called the police, so they were severely abused. 79.6%, a really scary percentage, had experienced some form of strangulation. Either they answered a yes to he tried to choke me, or an actual, so 11.7% only had tried to choke me. Actual completed strangulation was 30.16%, and that was a one time. And here's the multiple, which is extremely frightening. The 37.8% of these women who had called the police had responded to their call about domestic violence, had experienced more than one strangulation from this abusive partner. We also found, interestingly, and we haven't quite figured out why this was, but we did find that African American women had significantly increased odds ratios of experiencing both attempted, completed, and multiple strangulations. Now, here's also important, multiple strangulations was associated with more intimate partner violence injury, and this was both at the time of the interview and going forward, and the risk factors for homicide, including some alteration in consciousness, it was more likely to happen if it's multiple, and miscarriage. If they actually did lose consciousness, the good news was they were more likely to seek medical care and also to experience the sexual violence. So that's why the 10A, if yes, has he done it more than once, or did it make you pass out or black out or make you dizzy? Because that increases the risk of a severe or near fatal abusive event going forward, because it had a longitudinal component. So those of you that are certified in the danger assessment, you know how the weighted scoring goes. These are the top 10 gun ownership risk factors for a homicide by an abusive partner, perpetrator unemployment, threats with a weapon, leaving, estrangement, threats to kill, these are out loud, overt. If he avoided arrest for domestic violence, this is protective. This increases the risk also. The avoiding can be either by threatening her within an inch of her life, or what we say in Baltimore, boogieing the scene. But here's the strangulation. Now, we have not yet incorporated this into the weighted scoring. Stay tuned. We want to get it right. Those of you that are certified, we don't want to mess up your life in terms of changing the weighted scoring. But probably the actual, there was at least one strangulation event will increase the risk by 2. And this is where that 10A item's coming in, that if it's more than once and or to unconsciousness or some alteration in consciousness, will probably increase the risk by 3. Now we have to incorporate this into the weighted scoring. We're working with Dr. Jill Messing. We want to get it right. And when we do, it'll be on the website. Those of you that are certified, we're going to hopefully get an email alert out to people that are certified to go for the new scoring and the new weighted scoring, and to, the forms will need to be changed, etc. So stay tuned. That should be happening. We have thanks to OVW, a technical assistance center on assessing dangerousness in domestic violence situations. So that part of that work is to get this right and get this out there to everybody we know of. So the highly controlling perpetrator, stepchild, and physically forced sex increases the risk by 2. If she has a place of her own to go to, that's very protective. And so the other new advance is the Danger Assessment 5, the DA5, which also has the tried to choke or strangle you. If yes, did he actually do it? About how long ago? Did it happen more than once? Did you ever lose consciousness or think you may have? The DA5, it was recently published in the Journal of Advanced Nursing. That's the citation down here. We also have that available for all of you. And this was done with, the original one was done with an emergency room doc, Carolyn Snyder. So this is an important, that's the original one. This is the more recent one. So the important thing is that the DA5, the original one, had a different item for number 4, that it now contains the strangulation item, which is as much of an increased risk as anything else. It's a 5-item version of the danger assessment that can be used. We developed it primarily for the healthcare settings, but it can also be used in other settings. I always say it's important with whatever questions you ask, as important as that is the protocol that goes with it. So this is the protocol suggestions for use of the danger assessment. It can also be used, the DA5, at protective ordered hearings, child custody, disputes, etc., once domestic violence has been identified. If there are 4 or 5 yes responses, one of the most important things about the danger assessment is telling the victim that she or he is in danger. And then doing this kind of warm referral in terms of allowing the victim to choose reporting to the police and or to domestic violence advocacy program and or a confidential hotline. And you follow through by calling with the victim. So that's what we call, what Futures Without Violence calls a warm referral and or an in-person handoff to a knowledgeable advocate. In other words, you don't say, here's the phone number, call this number. You do that with the victim if there's 4 or 5 yes responses from the DA5. If there's 3 to 5 yes responses, do the full danger assessment. If you're not certified to do it yourself, get the victim to an advocate who is. Do the calendar and the weighted scoring, because this helps your accuracy, and it also is a process that is helpful to her. If 2 of 5, you tell her, there's 2 of 5 risk factors for serious injury, assault, or domestic violence, homicide present. And this is the basis on which you're going to highly recommend further advocacy. If the victim agrees, follow through with that same kind of, hopefully a warm referral or a handoff to a knowledgeable advocate. If there's only 0 or 1, you're almost going to refer her to domestic violence services, but your level of assertiveness is less strong. And here's a brief strangulation protocol that we put with it in terms of for healthcare settings that may not be well trained in terms of strangulation institutes, so primary care, prenatal care, etc. And then there's emergency, proceed with emergency medical care. Now this protocol can be, somebody can suggest a different way of doing the protocol. You may or may not need the strangulation with it, but it's important if you're going to use the DA5 that there is a protocol. So what happens depending on the number of yeses. And this is the LAP. Many of you may be familiar with it. The LAP is a short form of the danger assessment. It also has the, does he ever try to choke you? Sorry about the noise there. We got to get that phone unhooked up. So there's work to be done. There's the DAR, that's for women in same-sex relationships. We don't know much about strangulation for women in same-sex relationships. We do know that there are violent relationships between men. We don't know about strangulation in those kinds of relationships or other places on the rainbow continuum. There is a danger assessment for immigrant women. You can also get information about that on our website. The DA Circle for Indigenous women. We need to do better collaboration amongst all of us. And the Jeannie Geiger Crisis Center has developed the DALE for bail hearings based on the danger assessment, but that is only available through the Jeannie Geiger Crisis Center and their work on high-risk teams. So this is what I'll say at the end, because the danger assessment is for women who are abused.
Okay, well, thank you so much, Jackie. That was awesome. I feel like I'm in a live concert, but it was really good to go through that history and how it evolved. When I was starting to try to figure this out, you were one of the very first articles I read about strangulation. So thank you for starting it, continuing it, inviting others, and then sharing all this great information with us. Well, I want to tell everybody, as I mentioned before, that this particular webinar is 2 hours. We've also designed it to have a panel approach. So each one of our panelists will be able to share. We're also hoping that we will be able to take this webinar and break it up into nice chunks. So this way you can share it with your colleagues. It's almost like a line up. Hopefully Michael Burke from our team will be able to help us do that. We're getting now ready to switch to Strangulation 101 and delayed consequences. The way we were thinking of this is hoping that everybody is using the DA tool to try to help and assess the victim's danger. Then what is it that we need to know about strangulation, and what do we need to do in the sort of the acute setting when it just happened? As I introduce Ralph, I just want to say, Ralph, thank you so much for joining us. You were missed at the master's course. I don't know if you've heard, but we have over 1,300 people joining us today. But Dr. Ralph Rubiello, besides being also a good friend, he is the medical director of Crozier Keystone Health Network, as well as the medical director of the Philadelphia Sexual Assault Response Center. He also is a professor of emergency medicine at Drexel. But one of the things that I'm most proud of is that he too is part of our medical advisory team and has been guiding the way and doing some really good thinking as we have processed the victim who's been strangled. So Ralph, it is all yours, and welcome, my dear friend.
Okay, so welcome everybody, and thanks for being on the webinar today. Hopefully this will be a review for all of you, but for those of you who this may be your first strangulation webinar ever, and especially gracious welcome to you guys. And let's start at the basics. Let's start about defining strangulation. So we like to define it as a form of asphyxia or lack of oxygen that's characterized by closure of either the blood vessels and or the air passages of the neck as a result of external pressure on the neck. And when I use that definition, it sounds very lofty, very formal, but I like to break it down into some of its components to make it easy for people to understand, but also to highlight what are the important parts. So the first one is asphyxia. So there's a lack of oxygen or no oxygen. It involves both the blood vessels and the air passages. And that's important because we're often taught, or for years have been taught, that it's just the air passages. But we now know that the blood vessels probably play a more important part in this whole process. And then lastly, it's that external pressure on the neck. So we'll talk about what that means, but those are the big characteristics: lack of oxygen, blood vessels and air passages, and external pressure on the neck. Some other terms we like to throw around or use, and I think for the most part, they all could be used interchangeably because they're all part of the same spectrum. The first one is hypoxia, which just means a deficiency in the amount of oxygen that's reaching the body tissues. Anoxia is the absence of oxygen supply to a tissue. And then the last one is the one that we use in the definition of strangulation is asphyxia, which is any condition that will cause the body to be deprived of oxygen, causing unconsciousness or even death. A great example of that is to include suffocation in the process. So strangulation, suffocation are all forms of asphyxia, which can lead to hypoxia and anoxia. I think everybody by now knows that it's not choking, although like Jackie mentioned, we still hear a lot of our survivors and victims telling us that they were choked. And I think it's important when talking to our patients that we ask them specifics of what they meant by choking, see what their understanding is of choking. But from a purely medical perspective, choking involves blockage of the air passages due to something inside of the air passages. So you could choke on a piece of meat, a child can choke on a toy, but somebody is strangled when another person puts their arms or hands around their neck. So I like to teach juries and judges when I testify the difference, but we'll tell them that throughout the chart, you may hear the patient refer to it as choking. I mentioned suffocation earlier, and I think this is an important one to recognize because we see that this often is occurring in combination with strangulation, but especially in our sexual assault strangulations, we often see suffocation as part of that crime or assault. And this is where you obstruct oxygen from getting into the lungs, usually by sealing off the mouth and or nose by manual compression. So oftentimes we see it in the simplest form when a perpetrator is on top of the survivor and they start to make noise or they start to scream, or as a way to prevent them from making that noise, they'll put their hand over the mouth and face, thus blocking oxygen intake. That is suffocation. It can also happen by putting duct tape over the mouth and nose, putting the person's head inside of a plastic bag or a piece of plastic over their face, pillow, commonly seen, especially on movies and crime shows, a pillow over the mouth and nose to block that air passages. And the last one is a little bit unique, sitting on the chest. For those of you who don't know this, when you take a deep breath in, your chest muscles play a key role in your ability to get oxygen in. That movement of the chest wall is vital for proper gas exchange. By having somebody sit on the chest, that extra weight impedes the chest's ability to move and rise like it's supposed to, thus impeding the amount of oxygen that can come in and altering the gas exchange. And this is even more pronounced if there's a size discrepancy or a significant size discrepancy between the two individuals. So all of these are now being included or considered when we talk about strangulation, to actually say suffocation as well, or ask the second question, were any of these other things done to you to explain a suffocation? And Gail will probably talk or can talk more about a lot of the newer strangulation statutes are actually including suffocation or suffocation processes in their definitions. As we all know, two forms of strangulation, both described as either a ligature, where an object is used, like a cord or a necktie or a piece of jewelry around the neck, to accomplish the strangulation, and then manual strangulation, which would include a body part. So the hands, the forearm, maybe a leg, depending on positioning, describe our two forms of strangulation. By far, the most common one, and the one that I've seen almost exclusively, I would have to say over 94% of the time, my patients tell me that they were manually strangled by their partner. Now let's talk about what happens when somebody is strangled. And I'm going to mention the four important structures of the neck that we talk about: the muscles, the blood vessels, the bones, and the cartilage. I'm going to throw away muscles pretty quickly. You know, the muscles are important. They provide structure to the neck. They may also provide protection to some of the deeper structures, especially in people who have more muscular necks. But really, one of the things we see with the muscles is that these are very vascular structures, and oftentimes during strangulation, when they're injured, they'll cause bleeding under the tissue, and those are the things we see or we look for when describing ecchymosis, bruising, or subcutaneous hemorrhage from strangulation. It's oftentimes due to bleeding within these muscle groups. But they, in and of themselves, don't really contribute to any of the other signs and symptoms that we see regarding strangulation. Here's a schematic just showing you these. So this red structure right here is your carotid artery. Adjacent to it here is the jugular vein, which is much more superficial, much more to the outer portion of the neck. We know that the jugular vein brings blood from the brain back down into the heart and then into the lungs to be reoxygenated. And when it exits the heart through the aorta, it goes up the carotid artery to bring that nutrient and oxygen-rich blood back up to the brain. So jugular vein, carotid artery. Here is your hyoid bone, right here, kind of in the center of your neck. That's then connected to your thyroid and cricocartilages right here. And this here starts to show part of your trachea just underneath the muscle there. And this pinkish structure right here is your thyroid gland. I think I have some other pictures of what these look like. Here's another drawing showing the thyroid gland. Here's your jugular vein, your carotid artery. This is your larynx or your windpipe. This is your thyroid cartilage and cricoid cartilage right up in here. Okay. And I believe I have one or two more. This is the schematic that's available on the Institute website, showing the same thing, but more in a drawing form. Here's the trachea and the tracheal rings. Here's your thyroid cartilage. Here's that hyoid bone. Here is your carotid artery and your jugular vein. Now, one of the things we talk about related to strangulation, and one of the more serious effects of strangulation, is that loss of consciousness. So I'm almost always asked when I testify or when talking to a patient, why did I lose consciousness, or how did I lose consciousness? And it's really as basic as there's a blockage of blood flow or airflow or both. And probably because people are grabbing at someone's neck, it's probably a combination of both, because it's really not that easy to distinguish. I am specifically grabbing your carotid, or I am specifically grabbing your trachea, and air passages, or I'm specifically grabbing your jugular vein. So it's the blockage of the carotid arteries, because that will definitely stop blood flow to the brain, and the brain won't get oxygen, and that can lead to unconsciousness and eventually death. The jugular veins, if they are blocked, that'll block the blood from coming out of the brain, and that leads to venous congestion. That blood that's trapped up there is devoid of oxygen and nutrients, and that just sits there and stagnates, and that stagnant hypoxia is what we call it. That just stagnant lack of oxygen will lead to unconsciousness as well. Also, the jugular veins, as they're compressed, that pressure will build up inside of them and get transmitted to the smaller capillaries and venules, and those will rupture, and those are the petechiae that we could often see. So if we don't see petechiae, there's a possibility that it was more of an effect of the carotid artery. And I'm sorry, I went ahead too fast. So the jugular vein is responsible for the development of petechiae. The other way we do it is occlusion of the airway itself for the trachea, and we'll see in a subsequent slide that that's a little bit harder to do and probably overall plays less of a role. And we'll skip over the carotid sinus for now, but just be aware, carotid artery, jugular veins, and airway are probably the biggest ways that people become unconscious. So that carotid artery occlusion, remember the artery is a little bit stronger, and it could take 11 pounds of pressure that will occlude it, and that can lead to unconsciousness. Jugular vein occlusion, a little bit more lateral, easier to get to, a little bit of a weaker structure because it's a vein, only about 4.5 pounds of pressure. If you compress either of these, jugular vein for less time, carotid artery for a little bit less time, jugular vein for a little bit more, and I'll have another slide about this, you'll lead to unconsciousness. So this is the pathway that we see in probably the vast majority of our strangulation patients. It's that one or both of these blood vessels are blocked. Tracheal occlusion, this is usually very minor role in causing death, and that although we oftentimes will see fractures of the trachea, and those could be pretty bad and could require things like surgery and tracheotomy to fix them, they often don't cause death. And part of the reason is that it takes a lot more pressure, almost 33 pounds to fracture the trachea, and probably about 38 to 40 pounds of pressure to really collapse that trachea down and actually totally block oxygen. And as you know, if you've attended any of our other trainings, hyoid bone fractures, extremely rare, probably way more common on television shows and crime shows than ever imaginable in the real population. So if you're gonna hang your hat to diagnose strangulation on the hyoid bone, you're gonna miss a lot of cases. And I'm sure a lot of us have practiced long enough to say that they have never seen a hyoid bone fracture. And I've been now doing this for 22 years, and I am in that majority who can say I have never seen a hyoid bone fracture. So get it out of your heads that you have to have a hyoid bone fracture, and leave that to the TV producers. This is a great schematic, also available on the website. And basically, this looks at the physiological consequences of strangulation. And basically, it puts it in a timeline. And this is based on the two studies listed below. One, a neurology paper that used strangulation for a different reason, or looked at strangulation for a different reason. And then the other one was looking at judicial hangings and that. So basically, if you look here at the start of this at time 0, this is where the pressure is applied to the neck and you occlude the carotid arteries. At about 6.8 seconds, you could go ahead and become unconsciousness. Now, this is an adult male and on average, so these times are a little bit variable from person to person, but are on average about 6.8 seconds. Then at about 14 seconds, you could have an anoxic seizure. About a second later, you could lose bladder control at 15 seconds. If that strangulation, lack of oxygen continues for 30 seconds or an additional 15 seconds, you could have loss of bowel control. And then some of the earliest deaths occurred at about 62 seconds, where death respiration ceases. The earliest was about 62 seconds, and the longest was at 152 seconds. So this wasn't going to be a math quiz for anybody, but if we know that 60 seconds is a minute, this is pretty quickly after a minute, and this is a little bit more than 2 to 2.5 minutes, well below what we hear or have been trained in the past about 4 to 6 minutes for somebody to become brain dead. So this is a lot shorter time frame than we're used to thinking. And if you remember, that number 4 to 6 minutes is usually from, or has been extracted from, animal studies. And the human brain is much different than an animal brain. So we've probably overestimated that time to death or respiration ceasing. And it's probably a lot quicker, maybe as little as 1 to 2 minutes later. So this is a great schematic that I like to use in my trainings, and it's also available, like I said, on the website. Also available on the website here are these schematics looking at signs and symptoms of strangulation. Gail could go over how you can obtain these, but once again, these are available on the website and can even be customized to your own clinics and centers, etc. There is a pediatric version as well as a female or an adult version, and it's also translated into Spanish for you. And basically, I like this because it takes you from the head all the way down to the neck and can highlight the various changes that we see. Some of the neurological changes, some of the things we look for in the eyes, like subconjunctival hemorrhages and petechiae and the tiny red spots, to here's a ligature mark on the neck, and here's some fingerprint and finger bruising on the neck, other facial injuries that we could see, but also things related to the chest, like chest pain and trouble breathing and shortness of breath, voice changes, hoarse voice, sore throat, other breathing changes such as pulmonary edema and extra lung sounds and shortness of breath, the neck findings, ear findings, such as ringing in the ears and that whooshing sound that patients sometimes will complain about. And then a reminder that to look in the scalp and look for petechiae and other injuries there as well. And they're pretty much often the same in the pediatric population. However, the pediatric victim may be a little bit more susceptible to the airway changes because their airway is not as well developed as an adult and may take a little bit less pressure to cause lack of oxygen and therefore unconsciousness. But I've seen these be used as a reminder so that the physicians and nurses in the hospital or the clinics have this as a reminder to ask the patients about. But also I've seen people have these available to the patient and they'll ask the patient, had they had any of these symptoms, and the patient can actually circle them or check them off if they've had them or noticed them. So these are a very valuable tool and resource for you. One of the questions that we're often asked is, when should we transport a patient to the hospital following a strangulation? I know myself and most of the people on the medical advisory panel, we would say that almost everybody should be transported to a hospital and get evaluated. But definitely if the person is pregnant or has any of life-threatening injuries, which includes difficulty breathing, difficulty swallowing, evidence of petechial hemorrhages, vision changes, loss of consciousness, or history of urination and or defecation. So these put this at a much higher risk. This indicates there was an alteration in cerebral blood flow and that patient needs to be assessed. The other thing we like to talk about are the potential delayed consequences of strangulation. This study by Dr. Taliaferro, Dr. Hawley, McLean, and Strack showed several delayed consequences, including things like delayed swelling in the neck and delayed throat complaints. hematomas or blood collections in the neck, vocal cord immobility, which is due to that nerve injury in the neck. Also, displaced laryngeal cartilage or cartilage fractures, they could be a little bit delayed. Fractured hyoid bones can be delayed in their detection but can cause severe pain. Airway obstruction due to swelling can develop after the fact. Stroke is another one that could be seen days, weeks, months after strangulation. And that delayed death from carotid dissection or blood clots and respiratory complications and that kind of stuff. So these are all some of the delayed complications that we see. Also, other complications include the development of post-traumatic stress disorder, depression, anxiety, suicidal ideations and or attempts, memory loss, chronic pain, chronic headaches, and other sleep disturbances. And currently, the big question we have, which we haven't been able to answer yet, and I'm not sure how long it will be before we can, but why does one person develop these long-term consequences and another person whose strangulation may be as bad or even not as serious as somebody else's go on to develop these long-term consequences of strangulation? So I think as we move forward with our knowledge on strangulation, this is one of the questions that we're going to hopefully try to answer or get a handle on what it means. This is also available on our website. This is our recommendations for the radiographic evaluation of acute adult non-fatal strangulation. Also on the website is one for pregnant women who have been strangled, and hopefully a pediatric one will be out soon. So here's the list of symptoms and problems that we can have, and these are ones that we think are very serious. And then here are our recommendations. And what we actually recommend is that CT angiogram of the carotid and vertebral arteries is probably the gold standard to detect carotid dissection, but also because of the CAT scan or the nature of the CAT scan, you could detect other injuries, including laryngeal injuries, soft tissue injuries to some degree, vessel injuries, and you could, if you're concerned about a cervical spine injury, you could use the computer program in the CAT scanner to reconstruct the cervical spine to look for a cervical spine injury. So this tells you what to do of who needs imaging, what to do when that imaging is positive, and gives you a choice of imaging ranging from the best, the CT angio, down to not recommended study like the carotid Doppler. And here it is just highlighted that, you know, CT angio or CT of the neck with contrast, MRI, MRAs, and those kind of things. But this is all available. And you don't have to get all of them. It's just pick one of these. And like I said, the best one to pick would be the CT angio. This is a list of studies, and this is why this is so important. You know, this highlights several cases in the literature of carotid dissection. There's 3 of them here that are listed as purely from domestic abuse, and the time interval between onset of symptoms and detection or the strangulation to discovery was 3 months, 3 months, and 6 months. But if you look at all of these delays for all comers who've had carotid dissections, it ranged from here 1 day, 2 hours, up to 8 days, 3 months, 7 months. This one was 10 years where somebody's symptoms or stroke were attributed to a motor vehicle collision they had 10 years earlier. So it is very common to have delayed presentation for these carotid dissections in our patients.
Well, thank you, Dr. Raffaviolo. That was a great presentation and right to the minute. So I can't thank you enough of sharing your expertise. And I think you make it very clear that if a victim is lucky enough to survive a strangulation assault, she still is at risk for so much more. And that's why we wanted to have this particular webinar. The other main thing that continues to amaze me is that when the early sort of research really show that everybody believed that if you were strangled, you were dead, and if you survived, you were fine. And we're definitely realizing that is not true. I'm going to make a prediction, not Bill, Ralph Rubiello, is I think the difference between one victim having those symptoms and another, I think we heard a little bit of a clue from Dr. Jackie Campbell, is those multiple strangulations. As I continue to learn more about concussions and multiple strangulations and the anoxic brain injury, the more that they get assaulted one way or another, the more consequences they're going to have. So as the research comes out, there's my prediction, how it all comes back to that. And also, we're not going to have time to talk about suicide ideation, but that scares me as well. So what we wanted to do now is take a poll to keep benchmarking how we're doing. So we're going to pause for that poll, and what we want to know from all of you that are on this particular webinar, has your hospital adopted the recommendations, whether it's the imaging recommendations or some form of it? Will you please let us know? At the end of this webinar, we have a survey for you. What we like to do is honor those who have done the training, convinced their hospital staff to do this. And right now we are getting those numbers up. We're at 28%, because the key to this is the imaging, because we don't understand what we can't see, and we can't fix what we can't see, but we have to be doing more than we've been doing in the past. And Dr. Rafa Villallo, you're going to be hearing about some of our family justice centers and programs that the more that we do, the more we learn, and we are identifying more victims with these findings. Right now, 67% has said no, their local hospital has not adopted imaging recommendations, which goes back to what Jackie was sharing with us, that we still have a lot more to do. But I'm really pleased to see that as the votes are coming in, and we will probably stop at about 60% because we're starting to slow down. We have 70 no and about 30% yes. So the other thing that we are collecting for the medical advisory team to review is report of finding. If you go to our website at Strangulation Training Institute, our team has come up with a very short survey, which allows you to say, yes, I'm Gail Strack from San Diego. We had a victim who came to the San Diego Family Justice Center. We had a forensic nurse. The forensic nurse recommended going to the hospital. She went, she got a CTA, and the results were. And if you have that, like a fractured high bone or some sort of carotid dissection or other finding, please let us know and we will follow up with you. I think, as we've mentioned before, the research is still evolving and we're still learning. So now what I wanted to do is kind of share some of the resources that we have specifically developed for frontline workers. And one of the first things out of the gate would be, for those of you who are on the call, especially our law enforcement friends, we have a new chapter for dispatchers. They are one of the true frontline responders, and that call from a victim who's asking for help from the police is critical. This is our opportunity here to dispatch the paramedics out to the scene. Some of you may know that the International Association of Chiefs of Police have made it very clear in their recommendation, where they recommend that all police agencies reconsider their policies and have a policy that once you identify a victim who has been strangled, to get the paramedics out there so they can do a medical assessment. Well, of course, if you're going to do that, you also have to make sure that you have recruited and have trained your paramedics to provide the type of treatment and assessment that they need. Right now, across the United States, there are only 2 states that have laws that require paramedics to receive training in domestic violence, let alone strangulation. We have 1 jurisdiction in Texas, thanks to Ken Shetter, who has passed a new city ordinance requiring their community to have a task force, to also have the paramedics to go to the scene. And Michelle Morgan will share what they learned very quickly within just 30 days of the implementation of their new ordinance and protocol. So I would take a look at this. Most recently, I was reading an article that was written by a paramedic, and the story she led off with was the paramedics who were not trained responding to a 911 call. determined that she looked fine, said she was fine, and the victim did not want to be transported. And less than 24 hours later, they were called back and she had died. So this is real, and I think it's really important that we warn victims of the danger, and we also track the offenders. I wanted to share with you on this legal piece because even though it was a law that passed in California, to me is critical. To me, it's a landmark, actually, statute, because as of this year, when police officers respond to a domestic violence call or sexual assault call and they determine a victim has been strangled, they have a duty to warn the victim how serious and dangerous strangulation can be and to encourage medical attention. We add much more to that, and we'll give you some suggested language, but the other key piece is duty to track. We now know, based on all the research from our research teams and people on this panel, that the men who strangle women are very different. They're very dangerous. They're probably the most dangerous offenders known out there. And we've been doing more work lately as to what's been happening after they get arrested or they don't get arrested or when they get released on bail or on their own recognizance. So we are tracking the men who strangle victims of domestic violence and intimate partner violence. We're seeing a link to those individuals also being involved in police shootings and mass shootings. But here's an example of what our advisory committee drafted for our law enforcement in California. But I encourage you to think about incorporating this into your own practice, because I think victim safety starts with educating victims about how serious strangulation can be. And if the victim keeps hearing the same message from each and every one of us, she will take a different course of action and not downplay this at all. So I wanted to share what many frontline workers are now using. It's called the Strangulation Assessment Card. This particular card initially was drafted by paramedics from San Diego for paramedics in San Diego. But as we started to pilot test it with various professionals, everyone suggested that this should be an assessment card for each and every one of us. You can use it at the dispatch call. You can use it if you are a hotline worker, if you are an advocate at the shelter, things that you should be considering when a victim has just been strangled. And I think the key piece here is really identifying that victim who's been strangled. What we have learned so far is many victims do not even remember being strangled. So understanding the signs and symptoms that Dr. Ralph Riviello shared with you is important. To understand the high-risk markers that Dr. Jackie Campbell shared is important. But what I also like about the strangulation assessment card, and this particular part was added by our medical advisory team, they added an advisal to the patient to make sure that they understand the danger and what to look for and monitor within the next 24 hours, and when they need to think about going to the ER or calling 911 for assistance. And then, because we realized, just like we did on this poll, that most hospitals have not adopted the imaging recommendations, we really do need to educate all medical providers as to what is available and what has been recommended. And I will say that the medical advisors did an amazing job of reading all of the research, thinking this through, and based on everything that they knew, there was expert consensus that this was the way to go. So what I want to do now is share some inspirations across the United States and how people are incorporating this. I think in the perfect world, if we can have forensic nurses involved in domestic violence exams all across the United States, that would be absolutely ideal. What we're going to do is share a little bit of practice from different types of programs, whether it's from Maryland, Oklahoma, or Texas, but we're going to start first. Suzanne Stewart. Suzanne Stewart is coming from Tulsa, Oklahoma, where Jackie and others did the big study of victims who were strangled using the Maryland model. So Suzanne comes with us. She's been the director of their Family Justice Center since May of 2010. She's also a really smart, sassy, brilliant businesswoman with 30 years experience in executive leadership. So Suzanne, I think you are online because I hear something. How are you, and welcome.
I'm good, thank you. The Family Safety Center has had a great benefit of having our forensic nursing staff in-house since we first opened our doors in 2006. And while we're fairly small, we're only at about 15,000 square feet, we're fairly robust when it comes to our programming. So just to give you a little overview of our client profile, this last year we had 5,600 adult survivors, 2,000 of their children, 1,500 of support and family members that joined them. Our forensic nursing staff of really one full-time person, but it's split between 2 nurses 5 days a week, did 1,150 forensic medical exams last year. Now, one of the great things about us having been open since 2006 and having Kathy Bell here since 2006 is that we have actually tracked through our danger assessments in the last 12, 13 years, the data that we're able to get out of those danger assessments. And so in particular, looking at the last 10 years for past life events or current events for strangulation, our statistics on the clients coming in to see us totally dovetail with what Jackie was talking about on the Oklahoma LAP test program, with 80% reporting either past life strangulation or current strangulation coming into our shop. We know that is a huge, huge issue for us. Here in Tulsa County, we have around 400,000 individuals in the city of Tulsa and some 750 in the county. So we have a large market that we serve, relatively speaking, and our numbers are continuing to go up. So as we've looked at these numbers and the expertise that Kathy has had for us going forward in our programming, Casey was in town about 1.5 years ago, and our law enforcement family violence unit detectives attended the strangulation presentation that he did. Our Sergeant Clay Asbell really got fired up with Kathy about strangulation, knowing our history, so that we came up with a protocol that includes having a victim service advocate from our domestic violence partner, Divis, who works with the family violence unit here, our 7 detectives, and developed a protocol for first responding law enforcement that has now been accepted as policy, not just by the Tulsa Police Department, but by all of those other law enforcement partners that are listed on this slide. And I think the thing that's interesting is that the first 6 months of our process, which means law enforcement informs the victim of the issues around strangulation, provides them some information. And Kathy will go into that a little bit more. But most importantly, I think our victim services advocate follows up with every one of those that allege strangulation within 36 hours or so, 24 to 36 hours. And as a result, you can see those numbers have increased 100% in terms of victims that we have seen in the same time frame this year over last year. So we're feeling very, very positive about the results of this. As I mentioned, it has gone county-wide, and it's fairly regular that we're sending somebody to the hospital every week or so for some symptom that may be related to strangulation. So I'm going to turn it over to Kathy now and let her continue.
Fantastic. I'm going to try to advance it and welcome Kathy Bell. Kathy Bell, as Suzanne mentioned, is with the police department and is a forensic nurse. She's been very active in the International Association of Forensic Nurses. She was the past president, but I also love and adore her because she's one of our medical advisors and has had an interest and shared my passion for this area and also research. So Kathy Bell, we're excited that you are on this webinar with us. Can you tell us a little bit more about what you do when you find out a victim has been choked or strangled?
All right. Like Suzanne said, when there are a number of different ways to get to the nurse in our system. She mentioned that law enforcement, the advocate in the law enforcement in the family violence unit is calling them. Nurses may make phone calls to those individuals after he's made that initial contact, and then between the two of us, that will bring patients in. Other patients will just walk through the front door because they found out about the program out in the community, or again, law enforcement has told them about it. There's an initial form, and I'll show you that here in a minute, that the individual completes, and then we have a criteria in place to get to the nurse. And then there is, even if they don't meet the criteria of the initial screening, that if they come into the safety center, they fill out the danger assessment and they identify strangulation there, they're going to be brought to the nurse. So that system has worked well for us. I don't know if I can make it advance from here or not.
I just did.
Okay, perfect. So you're seeing there the health survey. When they come into the front door there at the safety center, we developed this years ago because with one nurse there and all these patients coming in, we wanted to have an idea of kind of what type of medical issues were we, we're maybe sitting out in the waiting room while we're seeing a patient. So when they come in, if they hit these first 2 or 3, 4, they're going to be brought to the nurse immediately. And strangulation is one of those things. If they say yes to strangulation, they will be walked over to the nurse, or the nurse will walk over to where they are and at least put eyes on them. We may do some initial vital signs and then determine whether or not we need to see them immediately, whether we need to call an ambulance or what it is that we need to do. And then as we look at that whole kind of assessment there, figure out, and prioritize the individuals, then they're brought to the nurse. The nurse then completes a complete forensic medical assessment, and then we will refer those individuals. Anyone that gives history of strangulation will be also referred to the rapid intervention team here, and then that's going to provide those wraparound services. So they may get sent to an emergency department for further diagnostic testing, but then the RET will also be notified. And then we had just a short little, if you want to go to the next slide, if you can. Little case study where this is a patient, a 57-year-old that presented initially to the emergency department with dizziness. She said that she had been assaulted and strangled. And they did do the full assessment. They did do a CTA. This was one of the first hospitals that we had that actually included the CTA as part of their assessment. And they put as their impression probable acute parietal occipital watershed infarct consistent with a history of strangulation. She then came to the Family Safety Center where she got the emergency protective order. Back to the hospital, they wanted to do some more tests. They wanted to do an MRI because she also had history of a previous stroke prior to her her admission on the day of this acute event. She signed out AMA, didn't want to wait. So then a day or two later is when she came to the safety center where the medical documentation that was then done. The case proceeded to onto court, and at that point there was some problems with the physician in testifying. So they passed the preliminary hearing. The DA declined to prosecute at that point, although the case was left open. The next time we ran into this patient was when we found out that she was in the hospital. The domestic violence detective then identified, looked back and saw all this history. He then also went back to the district attorney and to relook at this whole case. and they've now reopened it, added to it, and it will be going to trial in a couple, 3 weeks.
Well,
So that's kind of how we go from,
Strangulation.
and right, it is a felony here. So that's kind of how we've been able to take it from the beginning all the way to the end. One other thing that with the strangulation initiative that we've put in place is that last year there were, within the Tulsa County, there were 18 homicides, and so far this year there have been 3.
wow. That is awesome. In fact, can you please say that again? I want to make sure everybody heard that.
So in 2017, in the Tulsa County, there were a total of 18 homicides. And then since January 1 till now, there have been 3 in 2018.
Well, I can just,
Let me add one thing to that too. None of the clients who've accessed services here at the Family Safety Center since 2013 have been victims of homicide. Either our high-risk cases or our regular walk-in the door cases. All of the people who've been victims of homicide have flown under the radar screen and have not accessed services from anybody that we can find out.
that is fantastic. And I think this is like living proof of what we have been talking about and the research says about homicide prevention initiatives. Includes family justice centers, it includes focusing on strangulation and using some sort of risk assessment tool to identify those high-risk victims and put other steps into place, including high-risk teams. So thank you, Suzanne and Kathy, and special kudos to Sergeant Clay Asbell, because without the 3 of you, with your leadership and your passion, you put all these ideas into action, and it's obviously making a huge difference. And it's a definite inspiration to us here at the Alliance and the Training Institute. And so now I want to share another inspirational story from Michelle Morgan, who is the Vice President and Director of One Safe Place at Tarrant County Family Justice Center. And thanks to Michelle, she is taking a leadership role in our advocacy committee as part of our national advisory team.
Yay! Well, hello, friends. It is a pleasure to be joining all of you. What I'm going to focus on today is kind of about our intake process. And so when you come through the intake, what does that look like? And then specifically on strangulation. So for those of you that aren't aware, we are located in Fort Worth, Texas. We serve our whole county, which is representative of 42 law enforcement municipalities, which is quite a large area to cover, and we're working with a lot of different jurisdictions. One of the things about coming into our Family Justice Center is we're a walk-in center. We switched to that years ago. We feel as though as you're dealing with the cycle of violence, that it's better for the victim, for them to be able to come right in before that honeymoon phase hits, so then they can meet with an advocate and really understand the full level of violence that's happening. And so when we started this intake process, which is the first thing that a victim, when they walk in, is going to walk through, we thought we were doing really great because we implemented all of Dr. Campbell's full-blown danger assessment. Man, we were scoring it. We thought we were doing really well. And you can kind of see here on the screen what our numbers look like. Last year, 58% of the victims reported being strangled or choked by their abuser. And then so far this year to date, we're at 59%. So that seems to be pretty consistent. What we see overall is that 62% of clients that walk in here are extreme danger. So what that means for us on that danger assessment is that victims come in when the lethality is really, really high. And then the majority of those that are scoring in that extreme danger category for us also are reporting that they've been strangled. So we thought we were doing really great. We were implementing the danger assessment. We were scoring it. We were talking to victims about their score. and then we went to the Alliance for Hope 4-day advanced course on prevention of strangulation, and that somewhat changed the landscape of what we were doing. We learned that there was so much more that we could be doing, and just asking the question about strangulation, because literally we would ask it and then we were done. We were like, okay, great. And then we would move on to the next thing. After going through the 4-day advanced course, we learned that there was more. So what we then, like I'm talking like we went to 4-day advanced course, and by the next week, we had implemented what we use is a strangulation questionnaire. So if the victim identifies that they have been strangled or choked, then the strangulation questionnaire asks things like, so how many times have you been strangled? What sort of method was used? The majority of the time it is manual strangulation, but then there are those other occasions where other methods may be used, and that's important to be able to know that. We also ask about any signs and symptoms. So, any of the things that the doctors previously discussed earlier. We also ask, was anyone present during that incident? And if they sought any sort of medical treatment, and if so, what was that? It's important to gather more information around strangulation so we can get a better picture of the level of violence that's been occurring within that relationship. What I tell people, and what's very interesting, is that the majority of the time previous to this, our victims have already told us what their story is, if you will. And the majority of the times in their story, nowhere in that story do they talk about strangulation. So it's important that we ask the question, and then we ask a little bit more follow-up details. The questionnaire, I think some people are like, oh, listen, I mean, our intake is already about an hour long, sometimes an hour and a half. So we don't have time to add a whole bunch of, 15 minutes or another 20-minute assessment to a very lengthy process. Literally, the additional questions that we ask on the strangulation questionnaire maybe have added about 2 minutes to that intake process. It's not long and it's not complicated, and it gets you a little bit better baseline. So for us, after we've done the strangulation, we also implemented a different sort of protocol. So if we have someone where strangulation has occurred within a 72-hour window, then we know that person, it's very critical that they receive that sort of medical treatment and evaluation. So we have a partnership with the University of North Texas Health Science Center, and they employ a health advocate that works on site at our Family Justice Center. And then we also have a local partnership with our EMS provider, which is MedStar. So the first process is, if we know that this person has identified that they've been strangled within 72 hours, the advocate is then attempting to get consent that we can provide a paramedic response on site at the Family Justice Center. So sometimes it may include the health advocate and the paramedic, or other times it just kind of depends on who may be available at that point in time. Depending on the signs and the symptoms, the EMS provider, so what will happen is the advocate at that point will then contact our EMS provider. They explain what the signs and symptoms are that the victim has told them through this process. And then they, at that point in time, decide whether or not they're just going to send what we call a critical care paramedic. It's like, I explain it to people because I didn't know that they existed. A critical care paramedic is like, it's like the SWAT team on the police department. So they're like the SWAT team paramedics, if you will. So they have a little bit more advanced skills and training. They don't drive around in an ambulance. They have their own police vehicles where they don't transport. Their response time to our Family Justice Center is probably about anywhere from 10 to 20 minutes. And so when we called, they decide at that point, based off of the signs and symptoms, is this an emergency response that is needed, or can they just send the critical care paramedic? So An example of that, if a woman is pregnant and she's been strangled within 72 hours or is also in addition having signs and symptoms, then automatically we already know that's an emergency response where not only we're going to get the ambulance, but we're also going to get other first responders that are going to be coming into the center to do an evaluation on them. So the medical, whichever medical professional is here, whether it's an emergent or whether it's a paramedic, they come on site here at the Family Justice Center, do the medical evaluation. They educate about the effects of strangulation, and we really try to get the victim to consent to transport to the local emergency room for more advanced imaging. The response for the medical personnel to the Family Justice Center is done at no cost to the victim. So we have grants and other things where there's no cost to the victim when they're coming on site. If the victim has to be transported, that's when either insurance, crime victims compensation, or other methods would need to be considered for payment for transport and then additional treatment. So after that initial response, then the protocol is that health advocate, whether they saw them or whether they did not, would then follow up with the victim to ensure that health needs are met and continue any additional advocacy or education that may be needed, and is also monitoring some of those long-term health risks that may come up later on after an emergent situation. So next slide, we have a case study. Keep going. So this was in April 18th of this year. We had an abuser brought a victim to one of our mental health clinics, and that victim had facial bruises. So the mental health clinic sent her home, but contacted CIT. So CIT stands for critical, I can't remember what the heck they're called, but basically they're crisis intervention team. That's what it is. Crisis intervention team. They are all police officers with Fort Worth Police Department, and then they also pair up with mental health social workers and counselors. And so they work together, they respond together. So that's why when that victim went to an MHMR clinic, they contacted that CIT team and said, hey, something's not right here. So the following day, on April 19th, the CIT, so the police department, along with a mental health person, responds to the home. They realize that there's been some domestic violence. They brought her here to the Family Justice Center. What's also cool about this is the crisis intervention team also works within our building, so they're very familiar with who we are and what we do. So they brought her here to the Family Justice Center, and upon meeting with the advocate, as you can see, MedStar was called. The only thing that the victim would say is that he kicked me in the throat. She was very severe, had some severe mental health issues, and so I understand it was very difficult for the advocates that were working with her to get hardly any information. She would be one of those people that we would talk about because of the mental health issues and the state of crisis that she was in, would not be able to sit through a traditional hour-long intake. And so the observable signs that the advocates noticed is that she had breathing problems, she had a raspy voice, and she had visible bruising on her face and on her neck, but the only thing that she would say is that he kicked me in the throat. So at that point in time, we implemented our protocol. Our EMS MedStar was provided. At that point in time, we did transport the victim to the hospital. Once she got to the ER, they completed a CTA imaging, and it was determined that she had a fractured hyoid bone. Even this case really demonstrates how important it is to have all advocates educated about signs and symptoms of strangulation. Had they not, because this victim was not able to communicate effectively and tell them all of those things, since the advocates knew what the signs and symptoms were, they were able to respond appropriately and potentially save victims' lives, and that's what it's about. Gail, you had mentioned earlier Ken Shutter, who is our president at One Safe Place. He is also a local mayor. He is a mayor of the city of Burleson, which is outside the city limits of Fort Worth. So yes, he successfully passed a strangulation ordinance that makes it mandatory when first responders are responding on scene that they have an EMS response, and they are all educated about signs and symptoms of strangulation and try as well to get victims to be transported for imaging. Within the first 3 months of implementing this new protocol and this new ordinance, the police department has received a 170% increase in the number of strangulation cases that they are seeing in the city. So what that means is that it's not that strangulation automatically is increasing in the community. It was just not being properly identified. And now it's being properly identified and they're properly responding to these cases. So thank you.
And as I understand, you've identified at least one victim with a fractured hyoid bone.
Yes, absolutely.
Okay, so I think with all of this education and screening, things are definitely going to improve for victims' health. So I'm going to start making some executive decisions. We are now at 11:48. I understand Audrey is on the call. So Audrey, this is what I'm going to do. To avoid having to go all the way backwards and all the way forwards, I'm just going to go put put this screen up that says, tell us about a recent case. Audrey, let me see if I can hear your voice, and I'm just going to ask you some questions. And then we will try to do this in about 7 minutes or less. And then we'll go to one thing that Dr. Jackie Campbell wants everybody to know about traumatic brain injury. We will schedule another webinar just focusing on traumatic brain injury and what do we do to help victims. And then I would say with the questions and answers, everyone, please keep typing in your questions. Before this webinar started, we've had a little inkling that we possibly will not be able to get to all the questions. So everybody on this panel has already agreed to answer your questions, and we will deliver those answers to you. So Audrey, welcome. Tell us about your program.
Okay, so the DOVE program is a hospital-based, advocacy-focused domestic violence program. So the thought is that, victims are coming into the healthcare setting. We know they're here. And so having a program within that setting helps to be able to identify victims of abuse. So we educate hospital staff to screen as well as recognize signs of abuse. So we have 2 screening questions. Are you afraid of or do you feel threatened by a current or former partner? And have you been hit, slapped, kicked, forced into sexual activity, or otherwise injured by a current or former partner? So an answer of yes to either of those questions, or a chief complaint of an assault by an intimate partner, or concerns from medical staff about injuries they've observed or medical or behavioral indicators that might indicate abuse, gets a call to the DOVE program. So we're available 24/7. We have trained advocates who come into the hospital. We use the lethality assessment, LAP, the 11-question shortened version of the DA. So we use that to assess for lethality. We do safety planning, provide education and resources, document in the medical record what the patient reported, and take photograph of injuries. We also are able to shelter immediately if needed. In addition to that, the majority of our patients are actually referred, or our clients are referred through the police department through the LAP Maryland model. So the police are at the scene of a domestic. They're using the LAP to assess whether or not the victim's at high risk for being killed. And then if they are, they put them in touch with us again through that 24-hour number to reinforce the findings from the danger assessment that they're at high risk, and to do some brief safety planning. We also get all the police reports from the 3 surrounding police precincts. So during daytime hours, business hours, we have advocates who attempt to engage the victims, provide case management, court accompaniment, assist with basic needs. We have a social worker who does therapy, individual and group. We've got an LAP coordinator who goes out with the police to do home visits. All of our staff can do the danger assessment as well. But in the fast-paced, ED or hospital setting, we use the briefer LAP. So in terms of strangulation, all of our staff have been trained that, especially when you hear about a longer assault or one focused on the head, face, and neck, that we want to ask, did the person put their hands on their throat? Was their airway or breathing somehow cut off? And so then from there, if they say yes, then we're asking more questions about how they were strangled. We're listening for signs that perhaps they lost consciousness, like when they say the room went dark or the room started to spin, as well as asking them about how their voice is sounding to them if they're having difficulty swallowing. So the next step is that we make sure that the medical staff are aware that they were also strangled. What we found is that victims come in, they've been assaulted, they're in much more pain from being punched in the face than they are from the strangulation. But we know that that could be more lethal. So we want to make sure that medical staff are aware of that. We also will talk to the patient about the lethality of strangulation, again, do safety planning. After discharge, we have a nurse who works with us who will call the patient to make sure that they understand their discharge instructions and they're following through with that, as well as connecting them with other medical resources. The police, when they have a strangulation case, they will do a supplemental report. And again, the domestic violence advocate and the domestic violence coordinator from the police department precinct go and do home visits and encourage victims to come in to seek medical care. We did develop a protocol back in 2008 for the ED physicians. At this point, I would recommend using the recommendations for medical and radiographic evaluation of acute adult non-fatal strangulation. That's on the Institute's website, because that is up to date, the most up to date recommendations. We've looked at almost 400 cases that have come in through the hospital, and some of the things that we've observed for those who have been strangled, about 84% do have police involvement. Excuse me, about half of our patients who come into the hospital have been assaulted. The other half are coming in with other medical issues. Of those, approximately 29% are also strangled when they're assaulted. But that has gone up. One year it was as high as half of the patients who were assaulted were also strangled. Police, we see that there's a higher percentage of assaulted victims, but a lower percentage that were strangled. We do either a CT scan with IV contrast or a CTA. That has gone from 0 when I first started working here to as high as 91% of the strangulation cases received that. On average, over 10 years, it's been about 68%. Approximately 71% of the patients have reported different neurological symptoms. So 46% reported headache, 14% were dizzy. Neck pain was the second most common area, with 67%. Dr. Riviela talked about suicide. We found 5% who were coming in for strangulation were also suicidal. And so, as he was saying, we're not sure what that was about, but it was just an interesting finding that we made note of. The other thing, we're not a trauma center. We have had 2 hyoid bone fractures, as well as 2 carotid artery dissections. So that was about 0.9% of those who were assessed using either CTA or CT with IV contrast had a carotid artery dissection. I think Dr. Smock has thought that perhaps about 1%. So, the more severe cases are going to a trauma center, and as a community hospital, we're still seeing some pretty serious outcomes. That's it.
Okay, Audrey, thank you. Record-breaking time. So I am checking in at 11:56. Congratulations on such an impressive and robust program. It's no wonder that you received recognition from the Office on the Violence of Crime on your work. So here's what we're going to do. I'm going to go to Jackie Campbell to kind of just summarize, maybe in 1 minute, about what we really need to know about traumatic brain injury, because we are coming to the end. I will also say, with your questions, keep typing them in. We will get back to them. And we will also give you a new date of when we will continue this conversation about the strangled victim who ends up having a traumatic brain injury and symptoms that go along with it. So Dr. Jackie Campbell, can you tell our attendees what they really need to know and the thing that concerns you?
In 1 minute or less.
There you go. You could do it.
I think the bottom line is that we are finding more and more, and we just published an article in the Journal of Women's Health, that abused women who are abused over and over again, oftentimes end up with long-term neurological symptoms. We are starting to recognize, and there's been a few MRI studies of abused women who have had repeated head injuries. We're starting to realize that these women are experiencing the kinds of trauma that we see in football players, the repeated head injuries. We think about boxers, what happens to their brains from repeated punches to the face, facial injuries. And we also know from the work in the Strangulation Institute that there are long-term consequences from strangulation in terms of neurological brain injuries. We oftentimes call them anoxic brain injuries. What we're only starting to put together is these, it's all one brain is what I say, that these long-term consequences for abused women may be the result of both an anoxic brain injury and the more common head injuries that abused women oftentimes experience, sometimes with loss of consciousness, sometimes a diagnosed concussion, oftentimes not. And it's that cumulative injury to the brain that we see things like women saying they're having difficulty concentrating, memory problems, those kinds of long-term neurological symptoms that oftentimes trouble abused women. They come to the healthcare system, oftentimes diagnosed with PTSD, which the idea is it only has to do with mental health, but there's also neurological issues going on. We're only just starting to think about what would be the appropriate interventions for those women. Sometimes safety is not the issue. The abusive relationship can have been long gone, but these injuries to the brain from both blows on the head, blows to the face, and strangulations, especially that repeated strangulation, is impacting their neurological health, their cognitive functioning long afterwards. So that's the 2-minute version.
Thank you.
More.
I think you really have summarized it well. I think the key for me was that victims are not just being strangled, they're having concussions, they're being beaten, it's repeated, they're not getting treated, they're not being healed, they're not being diagnosed, and it just gets worse. We will be providing these new articles that are extremely helpful. I have to read these articles a couple of times because each and every time I read it, I pick up something else. So you will be seeing this particular article about various strangulations. There's a new article on same-sex strangulation cases, brain injury, the invisible trauma. Also, this one having to do with the long-term neurological combination of strangulation and head injuries, recommendation for protocols. Then also we wanted to let you know that our medical advisory team, they're growing. They were, before the master's course, 25 strong. Now I think they're about 35 strong. And they're going to be taking a look and making some recommendations, much like to the imaging recommendations, about what we should do about the acute case where the victim is strangled and also the suffocation. The next time we get together, you're also going to be hearing a little bit more from Casey Gwynn. Casey Gwynn was not able to join us He's on his family vacation and enjoying some beautiful, I think in Idaho, scenery and weather, and of course his wonderful family. But cheering for the children, and in particular Hope Rising. We'll be spending more time in all of our work about the science of hope. And Jackie said it, and we had a aha moment in our master's course when she talked about why she does the calendar and trying to refocus victims to sort of think forward and not going back to triggering with the amygdala. But Hope Rising is giving victims hope for the future, coming up with a pathway, setting up goals, so they can get to healing much quicker. As handouts, you're going to get quite a bit from us. Not only is this being recorded, you'll get a copy of the PowerPoint, the things that Jackie will be talking about next time, the DA tools, the research articles, some of the resources from our friends in Tulsa, Oklahoma, and also Fort Worth, Texas. The questions will be answered. We will email those to you. The panelists have already decided that they were going to answer them no matter what. We have accreditation for the very first time for MCLEs for our California attorneys and CEs for nurses at a cost of only $25. We've got a lot of upcoming trainings in the next 3 months, so check us out. I'm seeing many of you at various locations. All of these sites have been making it available to others for free. If you are on this call and you're not on our mailing list, please take a few minutes to join the mailing list so you can find out about that next webinar and other trainings and materials. But I want to say thank you to everyone that's on this call who have joined us to listen in to some of our national experts and inspirational people who are doing great work. As many of you know, I started to do this work by accident. And when I was a prosecutor, 2 teenagers died under my watch, Cassandra Stewart and Tamara Smith. Both of them had been strangled before they were killed, and we didn't understand. There was a lack of injuries, a lack of training, laws, and protocols. But thanks to all of you on the call, we're making some progress, we're making changes. And I think when it comes to strangulation and traumatic brain injuries, the sooner that we can intervene, whether on the criminal side or on the medical side, there are going to be better outcomes for everyone. So special thank you to our friends at OVW, and special thank you to our friends at OVC. Thank you all for joining us and hanging in there for a 2-hour webinar. Hopefully we gave you some good information to think about, and we look forward to seeing you on our next webinar when we go deeper into traumatic brain injury. Thank you all. Have a great day.